All right, we're gonna get started. Hi, everybody. Happy Pride. Welcome. This is our fourth and penultimate webinar in our LGBTQ plus health speaker series organized by NYU Langone LGBTQ plus Advisory Council. I'm Ludo Devine. My pronouns are he and his. I'm an assistant professor in the Division of Infectious Disease here at NYU Langone, and Haley and I are the co-chairs of the council's social committee. So we have one webinar left in our series. You can still register for tomorrow. The seminar will take place at noon this time, not at 4 p.m. like today. And it will be animated by Dr. Christian Torres, who will be discussing LGBTQ plus healthcare disparities in kind of a broad sense. So today we're going to discuss cancer care for the LGBTQ plus community with Dr. Jason Domogauer. Hi, Jason. Hi. So Jason is a resident physician in the Department of Radiation Oncology at NYU Grossman School of Medicine. He's been especially engaged in local and national initiatives to improve medical education surrounding LGBTQ plus, and other sexual health topics. Most recently, he's been working with the NYU Perlmutter Cancer Center to increase faculty and staff training towards providing knowledgeable and compassionate care for LGBTQ patients and their chosen family. And he also serves as the principal investigator for multiple research projects that are focused on addressing disparities in cancer screening, treatment, and outcomes faced by LGBTQ plus individuals. So as for the other webinars, you can ask all your questions in the chat throughout the discussion, and then we'll be monitoring the chat and reflecting the questions back to Jason at the end. All our webinars have been recorded, so this one will be as well. We'll be sending, and I think actually you added the list, right, already in the chat. So Ailey just put the link to the YouTube list to which this webinar will be uploaded after, obviously, and then the one for tomorrow will be uploaded as well. And then later on, we'll be making those recordings most likely available to a larger public, whether through the Advisory Council or the NYU LGBTQ plus Center, who we are partner with for Pride events. And then finally, for all the information that you might want to get, or on the speaker series, or if you have questions related to LGBTQ plus health, I think you can directly contact all our presenters, but also you can email the address that's like right above my head, #outtoheal@nyulangone.org. And I think that's all. Jason, take it away.
Awesome. Thank you. And thank you for inviting me to speak on this very important topic during this very important week, during this very important month. So I really appreciate it. Let's make sure my slides. Okay, so I'll be talking on the intersections between the LGBTQ community and oncologic care. My pronouns are he, him, his, and I'm a resident in the Department of Radiation Oncology. So what are some of the learning objectives today, or what I hope to get across? So really hoping to identify the disparities in cancer affecting the LGBT person, summarize cancer screening recommendations for the LGBTQ plus community, describe ways that we can improve cancer care, and discuss what can be done at NYU. So just a brief check-in. So what is SOGI, as I'll be using this term quite often. So the SO of SOGI stands for sexual orientation, and that's who a person is emotionally, romantically, or sexually attracted to. And so, and I won't read off the slides, but these are different terms that you want to use in different things that people will identify as. The GI of SOGI, gender identity, is one's innermost concept of self as male, female, a blend of both or neither. And this can be different from the sex assigned at birth. And this is where if sex assigned at birth is male, for example, and your gender identity is female or feminine, this is where somebody would identify as trans feminine. And just as an example, and this can have varied derivations, and this is not an all-encompassing term or list of terms, so just to make that known. So the genderbread person is something that I do like to refer to. It's a simplified view of gender and sexual orientation, and it's just to really note the differences between gender identity, gender expression, biological sex, as well as sexual orientation. And I think it's a really good starting point for just having the conversation. I always think it's a good exercise for people to see where they would fall on this, because it's of note that it's a spectrum. A lot of these things are rarely black and white. very rarely does somebody identify as 100% of one thing. And so people really do identify on a spectrum. And it's also, once somebody's on, where somebody identifies at one point does not mean that's where they're going to be for the entirety of their lives. So that's why it's really important to check in with our patients and individuals across at various time points, just to see where they're at in terms of making sure that we know who they are as a person. So why are we having these conversations? So according to a recent Gallup poll, about 5.6% of the US population identifies as LGBTQ+, or approximately over 18 million Americans, and of which this number, about 50% identify as bisexual. So in New York City is known to have one of the highest number of LGBTQ+ identifying residents in the nation, or about 700,000 individuals, of which about 50,000 identify as transgender, or about 4% of the population of New York City. And New York City is also one of the most diverse cities in the world. So as such, many of our New York City LGBTQ+ residents are also at the intersection of multiple identities. And it's also important to note that New York City is not a homogenous population. So we have different neighborhoods and communities that are more prevalent in terms of LGBTQ+. And for those who've been in New York City for quite some time, know that these neighborhoods have changed over a period of time. Okay, so as I was mentioning, a lot of our individuals in New York City and elsewhere across the nation and the globe are at the intersection of multiple identities. And it's important to acknowledge that we all have multiple identities that intersect to influence who we are and how we experience the world, connect to others, and create a sense of self. And research and lived experience tells us that a positive mental health and well-being, as well as a sense of belonging, are strongly influenced by an inclusive approach to identity. On your left, you can see, I'm not sure if you can see my wheel, I really enjoy this identity wheel as it shows that there are various components that impact how we see ourselves and navigate the world. In the center of the wheel represents characteristics that are usually the most permanent or visible, and the outside of the wheel represents dimensions that are acquired and change over the course of one's lifetime. And the combination of all these dimensions really influence our values, beliefs, behaviors, experiences, expectations, and what truly make us unique individuals. The important component to also consider is that intersectionality considers how different identities simultaneously affect an individual's experience of privilege and or oppression. Notably that those of multiple minority statuses may experience effects of intersectionality or intersecting systems of oppression to a much greater effect that it becomes compounded. Multiple systems of oppression perpetuate discrimination and disadvantage based on factors such as race, class, sex, sexual orientation, and gender identity. Thus, it's important to note that if we import or improve upon some aspects of care for one specific identity, it may not equally benefit all individuals within that group. So it's important to note that we can't just focus on one specific demographic or aspect of identity and trying to improve upon a system. It's important to identify and reflect upon all the different intersectionalities of identity. So this leads me into the concept of minority stress. So those of minority identity or multiple identities often experience something referred to as minority stress. And this suggests that social situations do not lead directly to poor health for minority individuals, but that difficult social situations can cause stress for such individuals, which accrues over time, resulting in long-term health deficits. Furthermore, it's important to distinguish between distal as well as proximal stress processes. Distal stress processes are external to the individual, and these experiences include rejection, prejudice, and discrimination, whereas proximal stresses are processes that are internal and often the byproduct of these distal stressors, and they include concealment of one's minority identity, vigilance, anxiety about prejudice, and negative feelings about one's own minority group. And together, these two processes can accrue over time, leading to chronically high levels of stress that can cause poor health outcomes through engagement of high-risk taking behavior, poor mental health, and avoidance of healthcare. And it's important to note that LGBTQ+ individuals are recognized as a sexual and gender minority, and this is because of the result of past as well as current prejudicial and discriminatory practices. As you can see here on the left, just kind of really highlighting what I was saying, is a lot of these stressors can lead to different at-risk behaviors. So this is there's a lot of different general health disparities that affect the LGBTQ population, and Dr. Torres will be talking about this more tomorrow at noon. But I just really wanted to go over these because most of us know that cancer is a disease of aging. And so a lot of times factors of at-risk behavior or poor health can accrue over time. So the things to note is LGBT youth are 2 to 3 times more likely to attempt suicide and likely to be homeless. LGBTQ populations are higher risk of tobacco, alcohol, and other drug use, like I was talking about before. Cisgender, lesbian, and bisexual women are more likely to be overweight or obese. And transgender individuals, especially those at the intersectionality of identity, especially those of color, have higher rates of victimization, suicide, mental health concerns, HIV, STDs, and being uninsured. And then these unfortunately other components lead into our LGBT elders, and those individuals are more likely to be at risk of face social isolation, lack of social services, and lack welcoming end-of-life facilities, which I'll touch upon a little bit later. What's really important to acknowledge as I start getting more into the oncology focus is the LGBTQ plus community is at increased risk of certain cancers secondary to interpersonal stressors and structural barriers that precipitate increased risk behaviors that put all humans at risk. The community is not biologically at increased risk. It's because of the minority stress and other components and other higher risk behaviors or other behaviors that lead to cancer that put the population in our community at increased risk. And these oftentimes, there's other different cultural pressures such as increased sun-seeking behavior in gay men or things along those lines that we must take into consideration as we properly engage with our patients in avoidance of cancer and other components. And as you can see here, these are just some of the different factors that lead to cancer in all individuals that just have a higher prevalence in the LGBTQ plus population. So what are the numbers in our grouping, in our community? So approximately 81,000 individuals that are LGBTQ plus identified are diagnosed with cancer each year. And there are increased incidences and prevalences of these. So in lesbian and bisexual women, they are 2 to 2.3 times more likely to have any type of cancer diagnosis versus their heterosexual counterparts. Gay men are at increased risk of anal, prostate, and HIV-associated cancers and tend to be diagnosed at a younger age. Transgender individuals are 2.3 to 3 times more likely to have an infection-induced cancers. So as you can see, a lot of these are avoidable cancers because they are infection-induced or infection-associated. So the cancer care continuum is how I'm going to kind of have this conversation. And this is a very broad topic that can be broken down into numerous individual conversations. But I'm really just going to approach this kind of from like a 20,000 foot focus, just to get a sense and just to give some education on this topic. So the cancer care continuum has really been in use since the mid-1970s. It is a term used to describe various points from cancer prevention, detection, diagnosis, treatment, survivorship, thrivership, which is a new term that I really like, and end-of-life care. And this is a useful framework and model to view how patients' plans, progress, and priorities, as well as providers, institutions, and public health organizations are used to identify one's process through the cancer care. Through cancer treatments and better understand different healthcare disparities. As one would expect, this is a very oversimplified graphic, but one which is helpful to kind of break down the conversation into more discrete parts. So detection and screening. So the LGBTQ population is less likely to receive preventative cancer care services. And why is that? And there's a multitude of reasons. This can be from a lack of primary care provider, lack of health insurance, which is especially important and notable in our trans population, prior negative experiences with screening, and a lot of this comes from gendering of cancer screening. So one example can be if you're a transmasculine individual who's being screened for breast cancer, oftentimes you'll be going to a women's imaging center in a women's clinic, and in that room you may be sitting with a lot of female presenting individuals with a lot of different graphics on the wall in a pink gown. So a lot of these things are viewed in terms of a cisgender heteronormative kind of view. So you may not necessarily see yourself on the wall or reflected in the type of screening that you're going for. So a lot of these gendering will put a lot of people off in avoidance because of these anxiety-provoking situations. Patients and providers also tend to have a lack of knowledge on what screenings are recommended for a specific individual. And there's often various and pretty significantly documented cases of patients or individuals being declined or denied care based upon their identity. For example, and there's also well-researched components. So There was a research study that surveyed 2,500 transmasculine individuals and found that about 40% of them delayed care because of the fear of stigma or anticipated or enacted stigma. So this is a really, I think, thought-provoking or attention-grabbing component. And one of the ways that we can address this is if you got it, screen it. And so this is a really useful tool for both providers and patients to have a better sense of what screening recommendations would be applied to them. And so here is a table that I've put together just to kind of get a sense. This is not an all-encompassing one, but it's just to give us a little bit of a sense of what different screening recommendations are there based upon the individual, if you got it, screen it kind of component. So breast cancer screening, there's various levels of different recommendations, but annual mammogram starting at the age of 45 without family screening. For trans women, so those who are sex assigned at birth as male, for various levels of transition to identify as trans feminine, the recommendation is 50 years or older and 5 years of hormonal therapy, then screening every two years. For transmasculine individuals, if they've had breast reduction or intact anatomy that still have residual breast tissue, the standard breast screening is still at play. For those who underwent gender-affirming surgery who had bilateral mastectomy, no screening is currently recommended. However, there is a caveat to that even with bilateral mastectomy, there still may be residual breast tissue. And a lot of times it's based upon if you did have a bilateral mastectomy and there was any sort of concerning features in the pathology specimens, you need to have a conversation, or there should be a conversation with provider of what additional screenings may be at play in the future, whether that be MRI, clinical chest wall exams, or things along those lines. For cervical cancer screening, typically begins at the age of 21 and just follow one national guideline. For trans women, no screening is recommended because there's no need to surgically to screen a surgically constructed neovagina. For trans men, standard screening unless it's surgically removed. But it's also important to note that the provider lists that the patient is on testosterone because this can impact the view of by the pathologist. Anal cancer is a very important one that has that's very limited in terms of the recommendations currently. There's no official recommendations, but this is something that does apply across the spectrum regardless of one's identity. So if there is a cisgender woman or anybody with a cervix who's had a cervical or vulvar cancer that's HPV related, they recommend this being screened because anal cancers tend to be HPV associated. Those who are immunocompromised, either HIV positive or organ transplant, also be recommended for screening. For men who have sex with men and are HIV negative, every 2 to 3 years anal pap screening, or those who are HIV positive every 1 to 2 years, and the same across the remainder. There's no differences in terms of longo or colorectal screening. For prostate cancer, typically right now it's really discuss this with your provider. For trans women, if not removed in gender-affirming surgery, then it's the same as cisgendered men. However, there is a component of taking into consideration how the exam is performed, as well as adjusting the levels of PSA upper limit of normal. Typically, the recommendations currently are for standard recommendations is 2.5 to 4. However, if somebody is on hormonal therapy, to lower that upper level to 1. And we can discuss that in greater depth later on. So I think it's very important to note that the treatments are the same. So the biology and physiology is no different between whether or not you identify as LGBTQ+ or non-LGBTQ+. And the same goes for the treatment modalities. Surgery tends to be the same for, again, caveats. Radiation is the same. Systemic therapies tend to be very similar. And also the side effects. However, how we discuss which is the most appropriate treatment modality and what those side effects mean is really where the important conversation has. A lot of times our treatment decisions are really going to be focused on what are the side effects component. And we tend to not do a very good job discussing sexual side effects at baseline. However, these are often, when discussed in a very heteronormative way. And what do I mean by that? Heteronormative leads to the assumption that the individual's sexual behavior is that of a cisgendered heterosexual individual. And examples of this discussion include discussion of erectile function in a cisgendered man undergoing prostate cancer treatment. And the focus of many of these conversations, as well as subsequent screening, including the sexual health inventory for men, is focused on vaginal penetrative intercourse. And this really fails to recognize that erectile function is different for anal intercourse, or that the conversation of treatment side effects and sexual health would be different for those who are the receptive partner for anal intercourse. And this is also true for other treatment sites, including anal and colorectal cancer. The other conversation is post-treatment care. So if somebody underwent bilateral mastectomy because of breast cancer, the conversation shouldn't automatically jump to reconstructive options, because that may not fit into the patient's plan in the future. And so having those conversations up front are very important. It's also important to note that the psychosocial care and supportive services are going to be very different, or could be very different for the LGBTQ community, which I'll touch upon a little bit later. And it's also understanding of how are our patients going to navigate the system. Oftentimes in oncologic care, you have many different providers who are giving very different services. For example, a radiation oncologist, surgical oncologist, medical oncologist. So you oftentimes are seeing or receiving care simultaneously. And so how is one being respected in each one of those departments by each of those individual staff members in those departments becomes very tricky. Another component is, for example, in radiation oncology, say somebody's being treated and they require a full bladder for treatment to reduce side effects. This can be very challenging for somebody who is trans-identified or gender non-binary, especially if there's non-gender neutral bathrooms that one must have to then navigate while dealing with a full bladder that then has to be relieved. So there's a lot of nuances to this that are really important for us to consider. Another important topic that a lot of medical and just oncologists struggle with is the hormone use in oncologic care. Currently, there's no data that exists that suggests that hormone therapy increases cancer risk or worsens cancer outcome. And similarly, there's no definitive data regarding the optimal timing of gender-affirming surgery and or continuation of hormonal therapy in the context of cancer care. And oftentimes it can be very traumatizing to force discontinuation of hormonal care or delay of gender-affirming surgery because of oncologic care. So these conversations must be important, must be carefully balanced between the benefits of hormonal therapy and gender-affirming surgery with the unknown risk in the oncologic setting. Going the wrong way. Okay. And so this topic was briefly discussed more by Dr. Fino on Tuesday, and it's an important topic of fertility preservation. And this topic should really be prioritized prior to the initiation of treatment and should be offered to anybody of reproductive age. And I think it's important to also note that contraception should still be discussed in our cancer patients, because cancer treatment does not equate to birth control, and discussing fertility preservation does not mean a patient is sterile either temporarily or permanently. It's just to make sure that people and individuals have the options available to them in the future. Another thing to consider is surrogacy, and also fertility preservation can be very expensive, and a lot of times the cost does fall upon the individual or the patient. Dr. Fino did discuss some of the fertility options available, so I won't go into too much detail. Another important thing to discuss is family building and adoption. These are also options for patients who would still like to pursue family in the future, but may not necessarily either have the options of fertility preservation or it's not offered up front, or don't want to go necessarily in that direction. However, it's also very important to note that these services can also be limited and challenging for LGBTQ plus individuals, with some different organizations, adoption agencies outright refusing adoption to our community. So another important conversation is survivorship and thrivership, which is a term that I was recently introduced to that I really like. So many survivors who have completed treatment indicate feeling adrift without the tools or support necessary really to navigate their new post-treatment reality and quote unquote normalcy. Many often have questions about future primary care needs, late effects of cancer treatment, and profound fears of this disease coming back, with many people actually having symptoms related to PTSD or PTSD-like symptoms any time they have additional imaging or return to follow-up care. And survivorship care planning is used as a good way to help patients transition to this new period of survivorship. And in 2006, the Institute of Medicine issued a report recommending that every cancer patient receive an individualized cancer care plan that includes guidelines for monitoring and maintaining their health. Unfortunately, Many survivorship plans fail to acknowledge the unique needs for the LGBT cancer survivor, since most clinicians do not receive sufficient LGBTQ plus education. Many lack an understanding of the needs of their LGBTQ plus patients, or may not fully believe that there are differences that need attention. And therefore, appropriate resources and referrals may not be present in the care plans for our patients. And thus few resources are available to support LGBT cancer patient survivors during their survivorship and thrivership period. And so this is unfortunately leads to some of the effects that we're seeing, that a lot of LGBTQ plus survivors report greater distress, more relationship difficulties, increased likelihood of substance use, poorer overall health, and generally overall lower satisfaction with their cancer care, treatment, and survivorship plan. And unfortunately, we just don't have a lot of data to really kind of lean on. Caveat being is that there was recently a survey, national survey conducted by the National LGBTQ Cancer Network, and this was called the National Survivorship Survey, which had a recruitment of about 2,700 individuals. And very proud to say that NYU was one of only 2 NCI designated cancer centers to participate in this. And so we're very strong supporters of this. And if anybody's interested, they are having a conversation on some of their initial results on June 30th. So while an unfortunate component, and unfortunately not an unexpected one, is end-of-life care and palliative care in the cancer setting. And so while obviously end-of-life services are not restricted by age, many of those who do receive those care and many of the LGBTQ individuals that require such services come from generations that have faced the greatest historical trauma and discrimination, and oftentimes, unfortunately, the setting of healthcare institutions. And that thus it's not surprising that many LGBTQ plus elders harbor expectations of prejudice. And so it's important to recognize that LGBTQ plus individuals, especially those who are elderly, or may also be single, less likely to have children, and more likely to be estranged from their birth families. And thus many of these individuals have families of choice. And these families of choice are composed of close friends, support group, ex-partners, various individuals. But it's also very important to acknowledge that, especially in the elderly community, these chosen families may be threatened by aging and their own illnesses, or have been significantly reduced because of loss during the HIV epidemic. And so, like I said, more and further going into that, more LGBT elders are more susceptible to depression, suicide, substance abuse, isolation, and facing difficulties accessing resources. And some of the data that's come out so far has shown that this has been even further compounded by the COVID pandemic. And so really focusing our attention now into both palliative and end-of-life care services. So these are often services that are delivered via a spectrum of services, and they are characterized by a series of transitions that occur on both a personal, family, and systemic level. Unfortunately, a lot for these services are not always viewed as accepting or welcoming or even available to those at the end of life care, especially in the LGBTQ community, because they feel that they will be treated with disrespect. Those who do end up pursuing these options, there's well-documented instances of people going back into the closet due to fear of being disrespected, not cared for, or just being faced discrimination. Other components are many feel that their partners may not be fully recognized, or may not be able to serve as their durable power of attorney for medical or end-of-life decision-making. And so those without a legal partner or paperwork specifying their wishes often face having their family members that they may not have spoken to for years or decades coming in and making decisions on their behalf. And this is very relevant for the trans population, who may be feared that their wishes of being recognized and die as the preferred gender will be disrespected. And so for many, having a power of attorney is a very important component for our LGBTQ plus seniors, or any individual at the end of one's life. Another thing that's important to discuss, as I mentioned and I alluded to a little bit earlier, is chosen families or lavender family. And there's a lot of history behind the term lavender family, but I won't go into too much detail of that now. But it's important to acknowledge that cancer does not just impact an individual, but it impacts one's family, one's community, and so many other individuals. So it's important for us to also acknowledge the providers, caregivers, and chosen family of our LGBTQ plus cancer patients. And again, as I mentioned, many times these are non-biological family members or families of choice. And often, and unfortunately, a lot of times such support persons may not always be welcomed in a healthcare setting because they do not have that biological legal time. And for those seeking caregiver support groups, a lot of times these are not either available for them or not inclusive. And so you may be coming as a cisgendered woman with a female partner going into a breast cancer support group and finding that the other caregivers are all cisgendered men. And so you may not find that those you may be heard, or the same experiences may not be shared or may not be appreciated. The other component is there tends to be more complex legal issues surrounding end-of-life care decisions and finances that I kind of mentioned on a little bit earlier at the end-of-life care slide. Like many other minority groups, there's still significant absence of LGBTQ plus individuals in clinical trials, both in terms of treatment clinical trials, quality of life clinical trials, and outcome clinical trials. And many clinical trials don't even take on or ask about SOGI demographics. There was a report that came out back recently in 2020 that examined 764 trials conducted between the years of 1991 and 2007, and found that 0 out of the 764 trials reported sexual and gender minority or LGBTQ plus status of its participants. Further along those lines, many of the largest cancer clinical databases do not include information of SOGI or sexual orientation, gender identity. Therefore, it remains very difficult to determine treatment outcome differences or quality of life changes for LGBTQ persons following specific interventions. So how do we combat this? So knowledge is power. And unfortunately, a lot of our providers don't necessarily have the training, and that's stemming from undergraduate medical education to residency training. And so we really need to do a better job of training all of our medical providers, whether that be doctors, nurses, advanced practitioners, everybody else, whoever sees patients, to really have improved training. So we recently conducted a needs assessment within the Perlmutter Cancer Center, asking providers, both clinical and non-clinical, questions regarding their welcomeness or their comfort treating or assisting LGBTQ plus patients, their knowledge regarding specific health needs, and their interest in acquiring greater education. And our findings were very similar to that conducted by national studies by Gwendolyn Quinn, who's also a faculty member at NYU. And we found that most providers feel comfortable treating LGBTQ plus patients. Those who responded felt more comfortable treating the LGB over T patients. And the same was true in terms of confidence. So while people felt more comfortable, the numbers kind of went down in terms of confidence of knowledge, with again, the numbers showing that people felt more confident in their knowledge of LGB healthcare needs versus those of the transgender population. Other thing that was important that I was really happy to see is the vast majority of people want to learn more. And this is very important. We also found that this was more notable for providers early on in their training, as well as those who are advanced practitioners. And so there's definitely room to grow, and there's definitely a willingness to learn more, which is always a great thing. The thing too, the old saying that I treat everybody the same, this just unfortunately is not good medicine, because the same treatment is not going to be the best treatment for every person. As you can see here in this demographic, giving everybody the same bike is not going to give everybody the same chance of success. We really have to adjust our treatments or our conversations for the specific needs of our patients to get the best outcomes for them. So how are we doing at NYU? How many LGBTQ plus patients do we see at NYU, and do we see at the Perlmutter Cancer Center? And the answer is we just really don't know. And this is because of a lack of completed sexual orientation and gender identity patient demographics. The last time we really looked, we only had about a 30% completion rate of all of our patients for completion of SOGI data. And this leads to an invisibility of our LGBTQ patients and the community at large, and thus contributes to a lack of understanding of healthcare barriers, screening recommendations, treatment side effect conversations, inclusion of chosen family, treatment outcomes, and overall needs, and so much more. And unfortunately, this is not just an isolated experience for ourselves. This is a local and national issue that is well recognized throughout the world. So, and this again is well recognized. So their leading health organizations recommend the collection of SOGI data to better understand the unique needs and disparities facing LGBTQ persons. And this is acknowledged by the U.S. Institute of Medicine, the Joint Commission, U.S. Department of Health and Human Services, and Healthy People. And the old thing too is my patients may not feel comfortable answering these questions. So research has actually looked at answering that. And the vast majority of patients, about 97% in this one study, were comfortable with providers asking questions and would feel comfortable answering such questions again in the future. This study was also replicated in the Veterans Association and found that 90% of veterans were willing to complete SOGI questions too. So the vast majority of all of our patients feel very comfortable answering these questions. A notable component, though, is a review of 21 studies found that while most patients expressed willingness to complete SOGI questions and viewed them as important, many LGBTQ persons were hesitant to do so, and this because of the stigma and fear and homophobia of negative consequences because of the historical components of the stigma and bias. So other programs, including UCSF, have programs called We Ask Because We Care. And this is important because including our patients and their chosen family in shared decision-making, especially in an oncologic setting, leads to better treatment compliance, satisfaction, and outcomes. And it also helps us that by better understanding a patient's unique identity allows us to tailor these conversations and provide meaningful support, especially as patients transition through that cancer care continuum. But first we must ask. And so there's different ways of asking. And so simple things that I use are, hello, my name is Dr. D. I use he, him pronouns. What name and pronouns do you prefer to use today? Or would you like to use today? Open-ended questions such as tell me a little bit more about yourself. Do you have any concerns related to your sexual orientation, sexual health, or gender identity? Or just normalizing the process that in order to provide the best care for my patients, it's important that I know the unique aspects of their identity, which includes their gender identity and sexual orientation. How do you identify? Opening the door for such conversations will allow patients to start to trust and build that rapport with you to answer such questions. And it's also very important to acknowledge that these questions should be asked more frequently because a patient may not feel comfortable disclosing this information on the first go around, that it may take some time for the wall to come down to that historical distrust before they feel comfortable enough to disclose that information. For those at NYU, there just a little bit of an overview of how to enter the SOGI data. So one opens an Epic. You can see on the dashboard the screening component, preferred pronoun. One would click on this area over here. And then this would open up this window where one can then enter some of the information. Of course, it's not all encompassing, but it's a great place to start. And this is important because then it follows the patient so that the other providers are able to use this information to make sure that the environment is welcoming and safe for the patient. Another way of doing so is by clicking on the history component, which will open this up for sexual health components. So we really do need your help. This is an institution-wide, national-wide, global-wide effort, and everybody is important. Being that one person that creates a welcoming space for a patient can create all the change, especially in an oncologic setting. So I'm here as a resource that was said earlier. If you would like to join our SOGI team in the Perlmutter Cancer Center, if you want to just let us know what's working well for you, what experiences you've had, or if you have questions, or what additional topics or trainings would one like to learn. And it's also very important to remember that it's okay. It's okay to feel uncomfortable. It's okay to stumble with questions. We all must crawl before we walk. So really just starting to have those conversations will make future ones easier for you to engage our patients. So just to summarize in terms of LGBTQ cancer disparities. So there's a lack of inclusion of sexual orientation and gender identity in many cancer registries, leading to us not really having a firm understanding of treatment outcomes and quality of life metrics. There's less likely to engage in early detection and cancer screening due to minority stresses and the historical components of stigma and discrimination. And this leads to increased risk and poorer outcomes for certain cancers, again, acknowledging that we are not more innately biologically predisposed to cancer, but it's just because of this minority stress and other risk factors that it increases the incidence. And disparities are due, again, to a combination of social, economic, and behavioral risk factors, and that there's a lack of training, comfort, and/or stigma by healthcare providers. And this leads to a worse quality of life reported among LGBT cancer survivors and their chosen families. We also created, and if we have an opportunity, we created a patient and family advisory council within the Perlmutter Cancer Center to create an opportunity for patients and their chosen families to have an equal seat at the table to help guide the Cancer Center through its efforts to improve cancer care for our LGBTQ LGBTQ community. So if any of you have any interest in being on this, if you're a cancer survivor yourself or know of any cancer survivors that you treat or friends of family, please send them along our way. We'd be more than happy to have as much voice at the table as possible. And then here's some resources, both from the provider's point of view as well as patient's point of view. For providers, ways to get more training, to get more information. For patients, different support networks that are available to you that have a focus on LGBTQ plus needs and different support groups. Just some last thoughts. Every person deserves to be healthy, and that no one should feel scared about being treated differently because of whose hand they're holding as they wait for the doctor. I messed that up. Their hand as they wait for the doctor to arrive. So here's my contact information. If anybody has any questions, any concerns, I'm always available. More than happy to have those conversations. And any questions?
Thank you so much, Jason. We did have a good job, and thank you for your excellent talk in the chat. I think people very much enjoyed that. Are there any questions for Dr. Domogauer? Another thanks so much for that insightful talk. What training is NYU currently offering from Dr. Quinn?
Yeah, so currently most of the NYU faculty and staff have online modules in terms of LGBT training. What we're currently doing is we're using the information in Perlmutter Cancer Center is we're currently using the data that we had that I'd referenced earlier to better identify what would be the best use of the information, the best use of our staff and faculty's time. So we're currently developing different trainings that are going to be more geared towards first a general overview of the needs of the LGBT community, and then tailoring some of those additional trainings for the specific side effect conversations that they become more relevant for that specific provider. So if a patient does come into their clinic, that they are better equipped to have those conversations on different treatment related side effects or different needs and different support services to provide for those patients.
And Dr. Quinn also said, can you talk about how the needs of clinicians may differ from staff?
Absolutely. And so this was an important component of our initial study, because a lot of times the question on how are providers doing, where their comfort levels are, is not the full picture. So a lot of times patients will engage with both non-clinical providers or non-front facing. That could be security staff, that can be phlebotomists, people who don't have a direct role in determining what care is being provided to the patient. So these components are very important, because if you have somebody who comes to a phlebotomist and they're not treated well, or they are not treated with respect components, it can really turn and affect that component of that patient's experience, so they may not come back. And so it's important for us to acknowledge that every person who engages with a patient should have some level of training, some insight, and to feel engaged, because I think it's also important that we identify champions in these efforts at various levels of the patient experience. And so the training may not necessarily be the same. So does a phlebotomist need to know all of the, and I'm using a phlebotomist as an example, it's not all encompassing, nor do I say that all. But do they need to have the same level of in-depth training about side effects and things along those lines? They may not, but they should still be able to engage with how to engage a patient respectfully, how to use a preferred name, how to ask pronouns or use pronouns, things along those lines, to make sure that a patient navigating our cancer center is viewed so in a welcoming way at every level of care. I'm sure that answers your question.
Sort of on that line, can you sort of comment on if you do accidentally use a wrong pronoun or use a wrong identifier, how to address that situation with them?
Absolutely. Yeah, absolutely. And it's gonna happen. And I still have catch myself doing that as well. And I think a great way is just acknowledging it and apologizing, and then moving forward from it. So saying, oh, I apologize for using the wrong pronoun or the wrong name. What if you didn't ask up front, what name, what pronouns do you use, and make sure that it's documented moving forward. or just saying, I apologize, is something that I'm still getting acclimated to, and I'm working on improving it. So I make sure that your care, and as well as the care of others, is as optimized or as best as it can be. And that really kind of reinforces the importance of the documentation in the electronic medical record, because this now allows us to have the pronouns as well as preferred name all moving with the patient. Instead of having them to disclose or out themselves each time to each new provider, this provides an opportunity for this information to be following with them to make sure that their experience, the ownership of their identity, or the ownership of disclosing, does not have to fall upon them each and every time.
Great, thank you for that.
Of course. I think the real big thing is it's okay, especially for those of us who are new at having these conversations. It's okay to stumble. It's okay to learn. It's okay to grow. But if we don't do so, we'll never be able to provide the best care for all of our patients. So it's okay to start practicing and things like that. And I always tell people in my department as well, if you ever want to practice intervention or an experience, more than happy to do so and be that sounding board to kind of be the first walkthrough, if you will.
Are there any other questions? Aren't there also challenges in prostate cancer detection for trans women?
There are. And so prostate cancer is an interesting screening conversation where the recommendations have changed over the years in terms of PSA being the recommendation to PSA is not the be all end all. And so there's still a little bit of a back and forth in that conversation in terms of cancer and prostate cancer screening. This conversation is also very important in terms of trans women. So those, again, going back to those who are sex assigned at birth or have a prostate that hasn't been surgically removed during gender affirming care. So how do we properly screen those individuals? Unfortunately, a lot of times the individuals who have experience with negative provider encounters or declined care are such individuals in those seeking care because of either symptoms they're having or a concern. And so they never even get to the point of having those conversations. So yes, prostate cancer screening is still a very important conversation in trans feminine individuals that have a prostate. Different things that become adjusted is how the digital examination is done. So typically, those who do not have a neovagina, the digital rectal exam is used for screening of prostate cancer. For those who've undergone bottom gender affirming care, one can also and should also use the neovagina for screening just because of where it falls within the biology and the surgical changes. The other component to note, as I mentioned before, is the levels of PSA need to be adjusted based upon hormone use. So we shouldn't be using the same upper levels for PSA. We really should be lowering them down just because it makes it more of a sensitive test for those individuals. So those components are still needed to, and still conversations are still very important to have. So there are also very important challenges. And then that also brings in the question of care. And so if a patient who is trans feminine is diagnosed with a prostate cancer, what are the treatment conversations like? Are conversations in terms of surgical removal, radiation components, androgen therapy? So these are very multi-modality conversations. And so you can see again that there's multiple different providers that are all weighing in, and also multiple opportunities for a patient to experience just like unwelcoming care and having those conversations had rather.
All right, give it one more minute for any last questions.
And please feel free to reach out to me. I'll go back to my email in case anybody has any questions or anything along those lines. More than happy to answer anything.
Okay, it looks like that is it. So we will go ahead and end it there. Lots of thank yous in the chat. And thank you so much for your wonderful talk this afternoon. We are very happy to have you.
Welcome. Happy to be here.
Thank you, Jason. Thank you so much.
Of course.
And everybody have a great evening.
Have a great evening, Timon.
Thanks so much.
Bye.